లిఫ్ట్ చేయలేదు మేడం.
ఏమన్నారు?
లిఫ్ట్ చేయట్లేదు మేడం సార్.
ఓకే, స్టార్ట్ చేసాం. గుడ్ మార్నింగ్ టు ఆల్.
సారీ మేడం,
శ్రీకాంత్ స్టార్ట్ చేద్దాం.
మేడం కేసు ఒకటి బ్యాడ్ అయింది అందుకనే.
ఓకే ఓకే ఓకే. Today Dr. Naveen presenting the delayed recovery from anesthesia. Please start.
Thank you, ma'am. Good morning, everyone. Today's topic of discussion is delayed recovery from anesthesia, moderated by Dr. Anuradha, madam, HOD, Anesthesia Care Hospital. Today's topic contains the definition, phases of recovery. Definition, phases of recovery, causes of delayed recovery with elaboration, delayed recovery from regional anesthesia, and stepwise approach to management of patient with prolonged unconsciousness. Introduction, delayed awakening from anesthesia remains one of the biggest challenges involving anesthesia. The principal factors responsible are anesthetic agents and medications used in the perioperative period. Non-pharmacological causes may have a serious sequel.
శ్రీకాంత్, చాలా డిస్టర్బెన్స్ వినిపిస్తుంది. ఎక్కడి నుండో
Stop it, madam. Non-pharmacological causes may have a serious sequel, hence recognizing these organic conditions are important. Accurate diagnosis of the underlying cause is the key for the institution of appropriate therapy, but primary management is to maintain airway breathing and circulation. Definitions, recovery from anesthesia. It may be defined as a state of consciousness of an individual when he is awake or easily arousable and aware of his surroundings and identity. Coma is derived from the Greek word coma, meaning a state of sleep, and is defined medically as a state of unresponsiveness from which the patient cannot be aroused. So there are three phases of recovery. It is divided in three phases. First is immediate recovery. This consists of return of consciousness, recovery of protective airway reflexes, and resumption of motor activity. This phase usually lasts for a short time. Next is the intermediate recovery. During this stage, the patient regains his power of coordination and the feeling of dizziness disappears. This stage usually lasts for 1 hour. And the third one is long-term recovery. There is a full recovery of coordination and higher intellectual function. It may last for hours or days. Causes of prolonged unconsciousness after anesthesia. These are the several factors. First is the patient factors, that is extremes of age, geriatric patient, gender, genetic variation, comorbidities, body habitus, cognitive dysfunction, seizures, and stroke. The second is the drug factors like dosage, time of administration, blood gas solubility, metabolism, excretion, drug interactions, fluid overload, local anesthetic toxicity. The third is the surgical and anesthetic factors like long surgery and long duration of anesthesia, muscle relaxant usage, hypotension during perioperative period, hypoxia, embolism, cardiac and neurosurgeries, regional techniques with sedation, painful stimulation. And there comes the metabolic factors like hypo or hyperglycemia, hypo or hypernatremia, hypothermia, hypothyroidism, hepatic or renal failure, central anticholinergic syndrome, acidosis, and coagulation defects. Coming to patient factors, extremes of age, geriatric patients. Elderly patients have increased sensitivity towards general anesthetics, opioids, and benzodiazepines, and slow return of consciousness due to progressive decline in CNS function. The decrease in volume of distribution, clearance rate, and plasma protein binding results in high free plasma concentration of drugs. Furthermore, muscle relaxants, if given on weight basis, delay onset of action and prolong the drug effect in geriatric population. Pediatric patients, because of larger body surface area, heat loss is greater in children, resulting in hypothermia. And there comes the slow drug metabolism and delayed return of consciousness. Gender. Men are 1.4 times more likely to have a delayed recovery than women. Lower sensitivity to hypnotic effect of anesthetics in women may account for their faster recovery. The female sex hormone was postulated to play a role in the gender differences in recovery time. Genetic factors, unexpected responses, and prolonged somnolence after specific anesthetics are commonly associated with a genetic defect of the metabolic pathway of the agent or its receptor. Polymorphic changes in gamma aminobutyric acid 2 receptor can adversely affect the rapid reversal of propofol anesthesia. Also, variable prolongation of succinylcholine apnea is due to abnormal or absent plasmacholinesterase enzyme. Comorbidities. Pre-existing cardiac and pulmonary disease require adjustments in anesthetic doses to avoid delayed emergence. Significant lung disease decreases the ability to wash out inhalational agents. Congestive heart failure and decreased cardiac output prolong somnolence. The renal or hepatic disease can prolong action of anesthetic agents dependent on hepatic metabolism or renal excretion. Subclinical hypothyroidism may be diagnosed for the first time as hypothermia and delayed emergence. Response to L-thyroxine and thyroid profile will confirm the diagnosis. Adrenal insufficiency can also present as delayed recovery. Body habitus. Obesity with increased fat mass requires higher drug doses to attain the same peak plasma concentration than a standard sized person. Underweight patients are having a higher risk of slow recovery after vascular surgery and cardiopulmonary bypass graft surgeries. Cognitive dysfunctions. Patients with Parkinson's disease are more prone to post-operative confusion and hallucinations. Inhaled anesthetic agents have complex effects on brain dopamine concentrations. Patients with Down syndrome or mental retardation are particularly susceptible to delayed awakening. IV sedation in cerebral palsy increases the risk of hypoxia, and delayed recovery of more than 60 minutes is expected. Seizures. A post-ictal state may well mimic unconsciousness. Anti-epileptic drugs are known to reduce the responsiveness of neuromuscular blocking agents when given chronically. Stroke. Surgical procedures with increased risk of embolization are CABG, orthopedic, particularly joint replacement surgeries, peripheral vascular surgeries, and valvular and aortic surgeries. Fat embolism from closed chest massage, corticosteroid therapy, or tissue trauma may present as a delayed return of cognitive function. Coming to drug factors or pharmacological causes, residual drug effects. A heavy premedication or the relative overdose of the general anesthetic agents may be the cause of delayed awakening. Potentiation by other drugs like drugs such as tranquilizers, antihypertensives, anticholinergics, clonidine, antihistamines, penicillin-derived antibiotics, amphotericin B and immunosuppressants, lidocaine and alcohol will potentiate the CNS depressant effects of anesthetic drugs and delay emergence from anesthesia. Drug interactions. Patients taking MAO inhibitors or SSRIs may experience severe drug interactions with IV agents that can result in hyper or hypotension and post-operative coma or a full-blown cetrogenic syndrome. St. John's wort, ginseng, lithium, ondansetron, metoclopramide, codeine, fentanyl, and oxycodone are among many others. Patients taking bromocriptine or pergolide are prone to excessive vasodilation, exacerbating hypotension. Pharmacological interactions with neuromuscular blocking agents like aminoglycosides, diuretics, calcium channel antagonists, lithium, polymyxin B, OCPs, or local anesthetic agents will prolong neuromuscular block. Neurotoxic effect of chemotherapy drugs like L-asparaginase and vincristine can produce CNS depression. Duration and type of anesthetic use. The selection of anesthetic technique and anesthetic drugs determines the duration of unconsciousness. Recovery may be delayed if soluble volatile agents are continued until the end of surgery or long-acting drugs are given towards the end of the procedure. Coming to opioids, opioids produce analgesia, sedation, and respiratory depression. Dose response is affected by co-administrated sedatives and analgesia and by patient factors. There are two major mechanisms resulting in coma. One is respiratory depression and another is direct sedation via opioid receptors. The sensitivity of the brainstem chemoreceptors to the carbon dioxide is reduced by opioids with consequent dose-dependent respiratory depression and resultant hypercapnia. This may affect clearance of volatile agents and carbon dioxide. Both can cause unconsciousness. Active metabolites of morphine and meperidine prolong the duration of action, especially in the presence of renal failure. Treatment is by reversing its action by IV naloxone at the dosage of 0.5 to 1 microgram per kg every 3 to 5 minutes until adequate ventilation or alertness is achieved. The maximum dose of IV naloxone is 0.2 mg. Coming to benzodiazepines. Benzodiazepines are used for anxiolysis and pre-medication. Co-induction facilitates the hypnotic or sedative properties of other agents. It is used alone. Benzodiazepines are unlikely to cause prolonged unconsciousness except in susceptible elderly patients or when given in overdose. However, CNS depression can prolong the effects of other anesthetic agents. Benzodiazepines combined with high-dose opioids can have a pronounced effect on respiratory depression, producing hypercapnia and coma. Reversing the effect is with IV flumazenil at 0.2 mg per minute until desired degree of reversal is achieved. Usually, the total dose is 0.6 to 1 mg. Coming to IV anesthetic agents, propofol has a large volume of distribution at steady state and relatively long elimination half-life. The effect of propofol after TIVA is prolonged. Delayed emergence from thiopentone is observed in Huntington's chorea. Ketamine contribute in prolonging the effect of ketamine. Duration of unconsciousness is affected by context-sensitive half-life, amount of drug, co-administration with other drugs, and patient factors. Coming to volatile anesthetic agents, emergence from volatile agent and anesthesia dependent upon pulmonary elimination of the drug and MAC awake. The speed of emergence is directly related to alveolar ventilation and inversely related to blood gas solubility. Hypoventilation lengthens the time taken to exhale the anesthetic agent and delays recovery. Prolonged duration of anesthesia causes increased emergence time due to tissue uptake depending upon the concentration used and drug solubility. If vaporizers are not calibrated correctly, higher than expected dose may be delivered, especially if end-tidal drug concentrations are not measured. The release of bromide ions after halogen anesthesia may produce postoperative drowsiness. Coming to neuromuscular blockades, it occurs secondary to absolute or relative overdose of incomplete reversal of non-depolarizing muscle relaxants or in a patient with succinylcholine apnea. The patient may be in distress, agitated, typically twitchy movements of partial reversal may also be seen. Electrolyte disturbances cause cell wall hyperpolarization and prolong the block. Hypothermia is metabolism and acidosis donates protons to tertiary amines, increasing receptor effect. Prolonged apnea following succinylcholine is due to abnormal or absent plasma cholinesterase enzyme. Acquired cholinesterase deficiency is seen in pregnancy, liver disease, renal failure, starvation, and thyrotoxicosis. Patients with myasthenia gravis are very sensitive to non-depolarizing muscle relaxants. Increased sensitivity to muscle relaxants is also seen in patients with muscle dystrophies. Treatment is with cholinesterase inhibitors for antagonism of the non-depolarizing neuromuscular blockers. These are the list of drugs prolonging the neuromuscular blockade, interactions with the non-depolarizing muscle relaxants. Drug interactions are with volatile anesthetic agents, aminoglycosides, lithium, diuretics, calcium channel antagonists. Metabolic causes contributing to prolongation with NDMRs are hypothermia, acidosis, hypokalemia, hypermagnesemia, myasthenia gravis. Genetic causes like Eaton-Lambert or myasthenic syndrome. Local anesthetic systemic toxicity. Repeated doses of local anesthetics in highly vascular area intracranial spread of local anesthetics after spinal anesthesia, or accidental subarachnoid injection during epidural or interscalene brachial plexus block may cause prolonged somnolence, seizures, coma, and cardiorespiratory arrest. Coming to metabolic causes, hypoglycemia. Hypoglycemia is diagnosed when venous blood glucose concentration is less than 2.2 millimole per liter. The brain is totally dependent upon glucose as its energy source. The effects of hypoglycemia can be divided into those resulting from sympathetic catecholamine response and those caused by neuroglycopenia. Neuroglycopenia manifests as confusion, abnormal behavior, seizures, and coma. In the elderly population, lateralizing neurological signs are commonly seen. Postoperative hypoglycemia is most often results from poorly controlled diabetes, starvation, and alcohol consumption. Alcohol impairs gluconeogenesis and will exacerbate hypoglycemia in starved patients. Other causes include sepsis, liver failure, pediatrics patients, sulfonylureas, endocrine tumors, and hypoadrenalism. Hyperglycemia. Severe hyperglycemia can prolong unconsciousness after anesthesia. A venous blood glucose of more than 14 millimole per liter causes an osmotic diuresis, dehydration in the untreated patient. The effects of dehydration range from drowsiness to acidosis. Blood hyperosmolality and hyperviscosity predispose to thrombosis and cerebral edema. Intraoperative CVA may occur as a result of cerebral vascular occlusion, especially in diabetes, with microvascular and macrovascular disease. Causes of hyperglycemia include ketoacidosis, hyperosmolar non-ketotic acidosis, lactic acidosis, gestational diabetes, insulin resistance, pancreatitis. Coming to hyponatremia and hypernatremia. Hyponatremia most relevantly in neurosurgical patients who develop SADH or cerebral salt wasting syndrome. Hyponatremia is also seen in TURP, cerebral edema, and dysautonomia after absorption of hypotonic glycine into the intravascular compartment, together with direct central inhibitory action of glycine, results in delayed recovery. Coming to hypernatremia, it is a rare cause of delayed return of consciousness after anesthesia that has been associated with surgery on hydrated liver cysts. Iatrogenic hypernatremia due to intraoperative use of hypertonic salines. Coming to hypokalemia. Hypokalemia intensifies the effects of non-depolarizing muscle relaxants. Respiratory alkalosis with PCO of less than 36 mmHg results in reduced intracellular proton concentration and draws potassium into the cells. There is a reduction of 0.5 milliequivalents per liter of potassium per 10 mmHg reduction in PaCO2. Hypokalemia can also occur with preoperative use of diuretics, calcium gluconate, sodium bicarbonate, beta-adrenergic agonist, glucose, or insulin without potassium supplement. Mild preoperative hypokalemia without any clinical features could rapidly deteriorate after iatrogenic hyperventilation or surgical stimulation and delays recovery. Treatment approximately 200 milliequivalents of potassium deficit is required to decrease the serum potassium by 1 milliequivalent per liter in the chronic hypokalemic state. In acute situations, the serum potassium concentration falls by approximately 0.27 milliequivalents per liter for every 100 milliequivalents reduction in the total body potassium store. Peripheral IV correction with KCl should not exceed 8 milliequivalents per hour. Through central venous catheter, correction at 10 to 20 milliequivalents per hour may be administered, maximum 240 milliequivalents per day. Other electrolyte imbalance like hypocalcemia after thyroid or parathyroid surgery, hypermagnesemia after magnesium therapy in preeclampsia, and severe hypercalcemia produce CNS depression. Coming to uremia, uremia results in dehydration and cerebral effects attributable to cellular damage and distortion. The clinical effects of uremia are varied, but intracerebral changes may produce drowsiness, confusion, and coma. Hypothermia. Neurological and respiratory changes occur with decreasing temperature. Example, confusion at temperature of less than 35, unconsciousness at less than 30 degrees, and apnea at less than 24, and absent cerebral activity at less than 80. The direct hypothermic effects on brain tissue are compounded by cardiovascular and respiratory disturbances at less profound degrees of hypothermia. Cardiac output decreases with a decrease in temperature and arrhythmias occur. Low cardiac output affects circulation and drug pharmacokinetics as well as tissue perfusion. Coming to hyperthermia, temperatures above 40 degrees leads to loss of consciousness. Skeletal muscle destruction after malignant hyperthermia can delay recovery from anesthesia. Coming to respiratory failure, postoperative respiratory failure causes hypoxemia or hypercapnia or both. The causes of respiratory failure may be classified into neurological, pulmonary, and muscular. Central drive is lost during drug overdose with intracranial pathology and in patients with COPD or sleep apnea. Ventilation is affected by primary muscle problems, metabolic imbalance, obesity, residual neuromuscular blockade. Pulmonary disease states result in venous admixture, dead space, or both include pulmonary embolism, atelectasis, obstruction, aspiration, consolidation, ARDS, and transient acute lung injury. Hypoxemia. Hypoxemia through resulting cerebral hypoxia will depress cerebral function, ultimately causing cell death. Cerebral damage results from lactic acid production, free radical accumulation, and release of intracellular metabolites. Hypoxemia with continuing blood supply causes less damage than complete interruption of perfusion because toxins are removed. Coming to hypercapnia, it is detected by central chemoreceptors, initially stimulates respiration, but thereafter depresses the regulatory respiratory centers of the brain, causing hypoventilation and apnea. Respiratory acidosis results from hypoventilation, rendering the patient asthenic. Hypercapnia in a head-injured patient with impaired cerebral autoregulation causes vasodilation and a consequent increase in intracranial pressure, which may result in secondary brain injury. Coming to neurological causes, the common mechanism is ischemic brain destruction. Periods of hypoxemia or ischemia may occur during surgery. These are often as a result of inadequate cerebral perfusion secondary to MAP. Cerebral autoregulation in the normal brain occurs at 60 to 160 mmHg of MAP. Carotid surgery and operations in a sitting position present at a high risk of hypoperfusion. Intracranial hemorrhage, thrombosis, infarction can occur in association with intraoperative arrhythmias, hypo or hypotension, or in patients with abnormal cerebral vasculature. The outcome from ischemic events varies between discrete functional deficit, hemiparesis, and coma. In the brain with impaired autoregulation, injury may be caused by hypercapnia, hypoxemia, low mean arterial pressure, and increased metabolic rate. Cerebral hypoxemia may result when epileptic seizures are masked by neuromuscular blockade and from intraoperative air embolism. Finally, the spread of intracranial local anesthesia can cause unconsciousness. Postoperative neuroexcitatory symptoms. Symptoms such as twitching, myoclonic movements, office tonus, and seizures can present during induction, maintenance, as well as recovery from anesthesia. Other rare causes, central anticholinergic syndrome. Historically, anticholinergic syndrome was a commonly encountered sequel to anesthesia. It is thought to be due to decrease in inhibitory anticholinergic activity in the brain. Symptoms range from cerebral irritation with delirium, agitation to the CNS depression with stupor and coma. These accompany peripheral anticholinergic effects, that is tachycardia, blurred vision, dry mouth, and urinary retention. The symptoms are rapidly reversed by physostigmine. Anti-Parkinsonian, antidepressant, and antihistaminic drugs can cause central anticholinergic syndrome. Other rare causes include dissociative coma, myxedema coma, thyroid failure, Hunter syndrome, valproate toxicity, drug abuse, and lidocaine infusion for arrhythmias. Delayed recovery from regional anesthesia. Central neurological blockade. Vascular malformations and anticoagulant therapy with increased pressure in the vertebral venous plexus are common causative factors. Diagnosis is established by MRI. Narrowed epidural spaces, migration of epidural catheter, intrathecal migration of the drug, faulty infusion pumps, potentiation by fentanyl or clonidine are possible mechanisms of prolongation of the blockade. Coming to peripheral nerve blocks, patients with underlying neuropathology, such as diabetic neuropathy, exposure to neurotoxic chemotherapies, or disruption of the neural blood supply are more susceptible to peripheral nerve complications. Neurological deficits may persist for days after high-pressure intraneural injections of local anesthetics. Wound infiltration. Brainstem paralysis due to Buffekin wound infiltration after foramina magnum decompression and field block is also reported. Coming to a stepwise approach to the patient with prolonged unconsciousness. Rapid assessment of airway breathing circulation, supportive measures with 100% oxygen delivery, airway adjuncts, and manual ventilation. Should be checked whether the airway is protected or not. After that, rapid assessment of GCS, stimulate the patient, review the anesthetic chart, consider naloxone, flumazenil, neostigmine, and doxaprime for reversal of opioid or benzodiazepines. Drugs, timings, interactions, take account of patient characteristics like patient factors like geriatric patient, body habitus, any genetic factors. Check the capillary blood glucose, correct if glucose is low or high. Measure the temperature, warm if temperature is less than 35.5 degrees. Consider arterial blood gas analysis, correct hypoxia, hypercapnia or acidosis or any electrolyte imbalance. Consider full clinical examination with particular attention to the respiratory system and nervous system. Consider further diagnostic tests like chest X-ray or CT head, blood tests like urine examination, CBC, blood glucose. If the patient remains unconscious with the above management, decide where this patient should be managed, further course of action, and consider a dissociative test whether other diagnoses are absent. Thank you.
Thank you, Naveen.
Thank you.
Any questions from audience?
Good morning, madam. How do you differentiate central respiratory depression from peripheral respiratory depression?
So central versus respiratory depression.
That means drugs are causing central respiratory depression and peripheral respiratory depression. Clinically, we can differentiate.
For any prior traumatic brain injuries can lead to central.
No. Patient responds voluntarily. You ask him to take deep breath, patient takes deep breath in central respiratory depression. Whereas respiratory depression, peripheral, he will not do. Respiratory mainly opioid depression. If you ask the patient, encourage the patient to take breaths, he will take. What is the difference between SAADH and cerebral salt wasting syndrome?
So SADH is the volume, euvolemic status. Coming to the volume status, whereas the cerebral salt wasting, it is a depleted volume status.
So that is euvolemic hyponatremia and hypovolemic. This is hypovolemic hyponatremia.
Yes.
So we have to give fluids in cerebral salt wasting.
In SADH, there will be oliguric state, whereas the cerebral salt wasting, you can have a polyuric state.
What is the dose of vancomycin in respiratory failure? Renal failure. in adult patient weighing 50 to 60 kg.
It's around 1 gram,
1 gram, how frequently? Every 24 hours, 48 hours?
20 mg per kg we give.
Huh?
20 mg per kg we give.
How frequently you give? Interval, dose interval. 1 gram in 72 hours.
70 grams.
Any questions from Dr. Rani Madam, Dr. Shekhar, Dr. Omkar?
Hello. Good morning, Anuradha, Naveen.
Madam, good morning.
Good morning, ma'am.
Students unnar kada? Kranti, Ravi, Santosh. Are you there?
Good morning, ma'am. Yes, ma'am.
Yeah. Students, winnar kada class anta. Tell me the common causes where you see delayed recovery from general anesthesia. Common causes. What have you noticed? Em chusaru? And from this class, what else did you learn? Like what could other reasons of delayed recovery?
Good morning, ma'am. Old age and increased administration of relaxant and increased dosage of drugs.
Dosage of what drugs?
Sedatives and relaxant.
Inadequate neuromuscular reversal, madam, at the end of surgery.
Inka?
Yes, ma'am.
What else can cause hypoventilation in early recovery phase?
Improper suctioning during tube removal. Cause
Inadequate sleep.
Hypoventilation, I said. So if you give big doses of opioids towards the end of surgery, they can cause hypoventilation. They'll start breathing, you'll extubate, but hypoventilation because of respiratory depression, they'll hypoventilate. So what will happen? You may see little hypoxia. Saturation may pick up with oxygen supplementation, but we don't do as a routine ABGs. If you do ABGs in hypoventilated patient, you will see CO2 accumulation. If they're really drowsy and hypoventilating, they're requiring like a high concentration oxygens and all, then most of the times, as we do in CT cases, we also have to do in GOT if it is high requirement of oxygen, patient very drowsy, but we have extubated thinking that they are taking enough breaths. In those situations, you'll have to do ABGs. Then you know in hyperventilated patients, CO2 is going up. So it's not just the oxygen supplementation you need. You may need to use like a HFNO or NIV for some time to wash out the CO2 and also to give good enough breaths, maintaining minute volume. So minute volume is important there to wash out the CO2. If you have too high CO2 accumulation also, it will cause CO2 narcosis. Patient will become even more drowsy. So immediate post-op, you have to look for ventilation pattern, how they are breathing. If they are very drowsy, tongue fall occurring, then they won't breathe properly, tongue fall, obstruction. All these can cause not only hypoxia, they cause accumulation of CO2 and eventually CO2 narcosis. That's where for long cases, many times we put them on pressure support ventilation for few hours till they are wide awake and taking good tidal volumes. Or that's why in even CT, they ventilate the patient for some time till they are fully recovered and ABGs are good. Then only you get extubate them. Okay, so common things commonly first you have to think. Then in addition, all the comorbidities, elderly, all these also, they are the contributory factors for delayed recovery. So you have to think if it is a hypothyroid patient, maybe they're not taking thyroxine properly. So they can cause hypothyroid patients, like Addison's patients, all these can also have delayed recovery. And as he mentioned, antibiotics, some of them, and neuromuscular problems from before. So your PAC is very important and you have to anticipate this patient can have possible problem of delayed recovery. So you have to have plan if that happens, what should we do? And in counseling, some cases, we counsel them actually. In fact, before surgery itself, we say there's a possibility of requiring post-op ventilation for comorbidities patients, or if we anticipate delayed recovery, all these cases. So if you do proper PAC, proper assessment, you know the medications, you know the comorbidities, you know the consequences, then you know who can have delayed recovery and what steps you take to prevent the delayed recovery, like preventing high doses of all these doses, drugs, relaxants, and not to give at the end of surgery. And you should know the surgeon and surgery also. So you don't do such things at the end of surgery. You know the surgeon, you know how quick they are, you know how long it takes. All these, if we know, then it's easy to prevent such things. Thank you.
In a steroid dependent patient, you should always supplement the dose of steroid intraoperatively. And also you should not be very fast to give the reversal. You should always note where the last dose of muscle relaxant is given and give sufficient time for the drug to be excreted. Then only you have to give the reversal. If you are hasty, if you have given muscle relaxant and immediately given reversal, patient may go into dual block.
Okay, Naveen, Anuradha, thank you.
Thank you.
Thank you.
Thank
Very useful class for students. Thank you.
Thank you to all. Thank you, Navi.
Thank you.